Okay.
Come closer. So, it's mostly similar in the lumbar spine, with the difference that could you close except that in human this transverse process comes above the pedicle. In pig, the transverse process comes below the pedicle. So for that reason, for a long time I thought this is the facet. This is not the facet. This is the transverse process where we are not used to have it at that location in human, but in the pig is in that location, and they superimpose here. So in human, as you know, the transverse process comes above the pedicle.
Right.
Another thing is that depending on the level, it changes, but if you look carefully here, the pedicle here is not at the superior aspect, as you would expect with a human, but as well, even that changes, you know, depending, like look at this pig here, and here is the pedicle more or less at the superior aspect, but that's not consistent in pig like it's in human. In human, it's more consistent that the pedicle is at the superior end. Another difference as well that we are going to publish the data about is, we would call this foramen here, correct? And in the lower lumbar of the pig, that would be correct. In the upper lumbar, the nerve root coming actually through an extra separate hole here, that, right there, here. That you can see here is a little higher up. You see that there? This is where the nerve root is coming, and this is the foramen. They are not the same. Further down you get that bone spurs get thinner, and then they merge in the lower lumbar. In the lower lumbar they merge. So what that means is, you know, probably you don't see that in the imaging to that extent. One other important difference is that the depth of the vertebral body, since pig is on all four and we are human, we are upright, the depth is in human is probably 30 to 35% more than in pig. So in a pig, usually, you know, see, we did a usual olive approach here. With the usual olive approach, we knocked off the front of the bone off, because in a human that would be perfect, because the bone would be coming like that. But here in the pig, since it's shallower, it's going this way. The angle is perfect, but there's not enough substance to hold it. So, but once you have this consideration and you work it within your approach, I think at least in a good sized pig like this one, this is even better. This is a little bigger pig. That the approach would work exactly the same way, where we are pointing to the pedicle, but here we have to go a little farther up, and here. Unfortunately, we have a little technical difficulty. They got the pig out, and then we have to put bags in. Usually we have a better picture, but this is the spinal process here. The pedicles are huge in pig. And as a matter of fact, these are the border of the pedicle. We would be lucky if in our patient we had pedicle that size. But this is make a perfect case for doing a pedicle screw training on a student and a resident, because once you get used to putting in the big pedicle like that, and then you know you can adjust your approach and so on. But the characteristics are the same, obviously. You aim for the lateral approach, and you make sure by the time you pass the pedicle here, you haven't reached the medial wall of it. So that's for posterior, and that is more or less is part of olive. Olive, you know, at least we advertise it to the MIS posterior pedicle screw placement, which can be done effectively and less invasively. For the approach itself, let me put that away. For the approach itself, all the considerations are the same. Patient is prone. We have biplanar fluoroscopic imaging, and you know I could work with this. Maybe we can make it a little lighter. or change the contrast. Is there a way to make it a little better? And I use the telephone cable to sew the belly. Maybe that's not a good idea because we have the. Say that again. Is it somewhere here? Okay, that's okay. That's okay. Are you? I mean, for the olive part, all you care about is the disc space. No, don't worry about that. That's fine. Let be. That was good. Okay, that's good. Let me do that. So, for the olive part, for the posterior instrumentation, there are different constitutions, but for the olive part, all you care about that you are able to identify the lateral border of the bone, as well as you see the trajectory of the end plates. Sometimes because of the parallax, here you have a good parallel, you see the end plates. But that doesn't even matter. It matters that you see the trajectory of the end plate. Even here you see that's a straight spine, so you can get end plate in every level. In a human, because of the lordosis, you wouldn't be able to get that. But as long as in every level you see the trajectory, if the trajectory is here or here, it's okay. That's absolutely what you need to know. But if you get the end plate here, like that or like that, as long as you see that, it's workable. Because you just want to know how far from the lateral aspect you are in. That's all what you need to know from that. In the lateral view though, you need to see the end plate because that gives you an actual trajectory. You have to, for that level that you are working, for example here, this would be perfect for this level. You see the shadow of the end plates overlapping.
Don't you think lower end plate is more important than upper end plate?
I think
getting a sharp image of the lower end plate.
Yeah, but most of the time, when you get one, you get the
other. But if you got a scolly though, if it's twisted at that level, I think lower end plate is important to get on sharp definition.
Sure, yeah, absolutely.
Lower end plate.
No, I'm going to get it. Do you have an 18-gauge needle?
Should be right there.
여기서 우리가 여기서 인젝션을 했네. 백피디는 뭐 디스크 시험 발플레이.
그건 하나 한개 발플레이.
So in this case, let's go for.
Get out of your way here.
Let's get an X-ray, epilateral. Okay, you need to go a little lower. AP lateral. Open the back of the AP. X-ray. Again. 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 Okay, lucky. Now, in the surgery, I get sometimes pictures that are much worse than that. I mean, like 300 pound, BMI 50 and so on. So I see, believe it or not, I see everything I need to see, and I think you do see everything that we need to see. But just for impacts like that, and sometimes as well you see it better when you're afar than when you're close up. But this is the spinal process. I still see the pedicle, obviously the end plate here. And most importantly, I see the lateral border and I see the trajectory. That's all I need to see. And sometimes people are wondering, how can I work with something like that? But if you look at from afar and you know that you don't need to see all the details, but just the lateral border and trajectory, that's absolutely workable. So is that a new lateral?
Nope.
This is a new lateral?
There's your new lateral.
Is that a new lateral?
Yep.
So I still need to go lower, huh? Okay. Because I want to go after that one. X-ray? Is that too much, huh? No. Maybe we could get a lateral. That cannot jump so much. Again. Oh, we are switched. We are top down, up down. Switch them back and forth, please. Okay, now it makes sense. Now you see the pedicle is more closer to the superior end plate, but still not exactly at superior end plate. Again. Okay, we are getting there. That's it. Get the AP. Okay, now open the back two of the AP. Again. 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 Lock the back two. Okay. So, then the first step after this is again, is identify the actual midline. The spinal process should be exactly centered, which it is, I believe, here. And then it doesn't matter how it feels or looks, I always confirm that. Get the AP. Again. And I mark it. And then I mark the trajectory of the end plate in the AP. Again. Again. So, what I mean, I mark the trajectory, that's the trajectory. But, get the X-ray. Even if I'm like far away from that, but I'm parallel, this is not good, X-ray. Because I'm not parallel to that. This is X-ray. Good enough, X-ray. I'm obviously a little extreme right now. I try to be as close as I can. But as long as I know in which direction the end plate ends, that is actually good enough. So X-ray. Again. So I don't, that saves me time that I don't have to each time adjust my AP. As long as I know it's coming in this direction, this direction, this direction, because I may not get a good end plate on every level and I don't need to readjust it. So I have my midline, I have my trajectory. The next step is lateral. Lateral. And I know this is, I need to have a good end plate and X-ray. And I try to put it in the midpoint of the disc, X-ray. About that. Now, I mark the point here, and we call this the dome. I mark the dome. I put my finger here at the dome. Then I know from the dome I need to go that far down to be in the midpoint of the disc. Now I mark the same from the midline. So this is the midline of the disc here. So if I mark them, I get two lines. One from here to the dome, one trajectory equidistance from midline here. Our approach is for Olaf is usually between these two lines. In a big patient, like somebody who's BMI of 50, it may be like when you put the disc down and then you transfer it this, they may pass each other. But still, your trajectory is between these two lines.
You know the geometrical basis is 45-degree isosceles triangles. You can prove that if you draw it out, right? Into the middle of this space. That's basically.
That's a simple geometry.
45 degree.
You try to do that 45 degree, and that's the best approach for cabin triangle. Now, once we have this, depending on how, if you want to put the cage more anteriorly, you're not going to go more steep. So you go more to that. This is your window. You go here. If you want to put it more to the other side, like with scoliosis, that you want to pass to the other side, you go more lateral.
How about L5S1 too?
We get to that.
Yeah, more lateral.
Absolutely. So, and for first time for scoliosis, I want to be more closer to here to pass to the other side. And on top of that, there's a new approach that we have described. We wrote a paper about it called MIS-DLIF, direct lateral.
One question. Your theory is okay when there is no obstacle in between. I mean this disc space, this is the entry point.
Mhm.
If there is no obstacle here,
Mhm.
then you are right. But if there is a big facet like this,
Big
you cannot
osteophyte,
enter.
big osteophyte. No, this bypass all of them.
Like
This is you, with this approach, that oblique, that's not the fore lateral. You're absolutely right about that. When you are fore lateral, as described in literature, in the fore lateral, if there's in the fore lateral, you can go to cambium if everything is perfect. Here, you can go to cambium no matter what, because no facet is just a single geometry. No facet hypertrophy can be that fore lateral to put an obstacle on your way from this. That is
Because you're
what
anterior to the transverse plasma
but
membrane.
you are absolutely right.
Anterior
No.
to the transverse
Yeah.
plasma membrane.
This you are actually here. Here we on the pig, we are not anterior to transverse process.
Okay, in humans.
Because as we described in the pig, the transverse process is here on the bottom of the pedicles.
But in humans,
In the humans,
it's
when the transverse
below.
process here, it's actually, then you are actually anterior to transverse process. And for that reason, in the United States, you can code it as the anterior approach.
You don't have to worry about osteophyte because you're going anterior to the, okay?
But you're absolutely right, you know, in the fore lateral approach.
Yeah, you're going to get into the facade.
No, lots of people do fore lateral approach for like schwannoma in the transforaminal pathology or even extraforaminal approach. Then you have to possibly drill the lateral part of the facet and so on, but here has not this, after 700 case has never been a problem. Okay, so, but if you want to go more straight lateral, then you use this line. Another thing is, if you're doing 5S1, for the 5S1, what we have tried to do is, you know, to the olive, I started doing olive. In the first 6 months or a year, every second 5S1, I had to interrupt it, go open. Because exact olive doesn't really work. I cannot show it on this because pig's 5S1 is different. But generally, in the 5S1, I go more to lateral. I use this line to go, and I go. Additionally, then there is another consideration. You don't go in the plane. You go way superior. So, like, imagine this is the iliac crest. 5S1 is somewhere here, right?
Right.
So you do all the consideration that you do for thing with a different, that here you have two lines here.
Okay.
First of all, you don't use this or this. You come a little actually like that, and then you add another aspect to that. Are you feeling this? And then the other aspect is then you come as well here.
Oblique.
Yes. And you come oblique and more like a direct lateral.
Quarterly undulation. So you got
Yeah. And literally then, not only the iliac crest, but as well ala is here. Ala of the sacrum, you know?
There is also big transverse process 5.
Yeah, and you know, there's
You went anterior to the.
you go, yeah, you're truly direct lateral.
Yeah.
In the last 3.5 years, only 3 times I had to interrupt the 5S1 and go open. All 3 of them were the grade 2 spondylolisthesis. So it's a possible approach. We do it every day. I don't believe Ashley even have seen the one that I have interrupted and have to open it. Ashley hasn't seen that yet. It may come soon, but it's usually always they have to be a grade 2 listhesis, even grade 1 listhesis, no problem. But consideration is the same. Here, olive is somewhere here, steeper here, more lateral here. Direct lateral definitely here, and depending on the anatomy, maybe even just a touch below it. And in the 5S1, as well, transpose that to go oblique underneath. Sonia has gotten really good at that. But this is just after 6 months.
Weeks ago.
And that is just after 6 months. So it took me 2.5 years to develop it. As a matter of fact, we wrote the paper about 2.5 years after I started doing that. So now here, obviously then at this point, we just incision. The incision doesn't need to be bigger than what cage need to go in. So half an inch is more than enough. And the next step is where is that probe? Where, guys?